Okay, I hope you can hear me and you can see my slides. Okay, so good morning to everyone, and I'd like to thank both Vasily, Professor Kotis, but also Professors Tendoloris and Pazarlu for the kind introduction. My lecture is going to be about choosing diabetes treatment based on background cardiovascular risk, and to present you with the evidence that is available on this matter. These are my conflicts of interest. In 2019, the latest ADA-ESD position statement, consensus report actually on the management of hypoglycemia in type 2 diabetes, suggested that the choice of glucose-lowering medication in type 2 diabetes should be guided by the presence of established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, and only in those patients who do not have any of these conditions, choice of glucose-lowering medication should be guided by other principles. So especially for patients where atherosclerotic cardiovascular disease predominates, this was also advocated by the American Diabetes Association, both in the 2020 as well as in the 2021 standards of care, where they suggested that in patients where ASCVD predominates or where there are indicators of high risk for ASCVD, specific options should be used for treatment for type 2 diabetes, and specifically choice should be between GLP-1 receptor agonists or SGLT2 inhibitors with proven CVD benefits. To summarize the evidence that is available on this matter, I will present you with the main findings of two recent meta-analyses that we published in 2020 and in 2021 on the comparative effectiveness of glucose-lowering drugs for type 2 diabetes in the annals of internal medicine and in diabetes, obesity, and metabolism. To summarize the evidence, we systematically searched several databases from inception through December 18th, 2019, and we included data for more than 300 patients with type 2 diabetes for 21 agents from 9 different drug classes. And these were all trials with a duration of more than 24 weeks that reported data for mortality, glycemic, and vascular outcomes. For our synthesis and analysis, we used standardized methods. Namely, we used the frequentist random effect network meta-analysis, and the medications were all analyzed both as drug classes, but also for GLP-1 receptor agonists and SGLT2 inhibitors. They were also analyzed as individual agents. We analyzed the data in two main networks based on the use of treatment, either as monotherapy in drug-naive patients or as add-on to metformin-based therapy. Change in HbA1c, hypoglycemia, blood pressure, body weight, and were analyzed in the two main networks, whereas mortality and vascular outcomes were analyzed in separate subnets based on baseline cardiovascular risk, so low versus high severe risk as reported in every child. So these data are the main data that I'm going to use for this specific presentation. Assignment was based on the presence or absence of relevant inclusion criteria in every individual trial, and confidence in our estimates for all outcomes and comparisons was done using a standard methodology, namely we used the GRADE methodological framework and the cinema application. Starting from patients at low cardiovascular risk, we used data for drug-naive patients who were at low cardiovascular risk. And as you can see from the forest plots that I will show you in the next 5 or 6 slides, there were absolutely no difference between the different drugs. As you can see on every slide, there is a forest plot showing the difference between any of the comparators which are listed on the left-hand side and placebo. And you can see the point estimate for every comparison and the 95 confidence intervals. If the 95 confidence intervals cross the line of no difference, that means that there is absolutely no difference between the agent which is listed in the forest plot and placebo in terms of every specific outcome. So for cardiovascular mortality, there is no difference between any agent or any class and placebo in terms of their effect on cardiovascular mortality in low severe risk patients who are drug naive. The same applies to all-cause mortality, hospitalization for heart failure, myocardial infarction, stroke for patients who were drug naive at low severe risk. To summarize the evidence for patients at low severe risk who, however, use treatment as add-on to metformin, we use data from more than 120 trials. And as you can see, even for this category of patients, there was absolutely no difference in any of the outcomes that I will present you data for. So no difference between placebo and any of the drug classes or any drug for cardiovascular mortality. You can see all lines 95 confidence intervals are crossing the line of no difference for cardiovascular mortality, all-cause mortality, hospitalization for heart failure, myocardial infarction, and stroke, as well as retinopathy and amputation. So that means that in these specific patients, so patients who are at low severe risk, the choice among different agents or different drug classes should be guided not by their effect on cardiovascular outcomes, but rather by their effect on other outcomes like HbA1c, where you can see that there are significant differences between the different agents or drug classes. And actually, you can also see, according to the color used, the confidence we have in our results, depicting results which are we have high confidence in the results with green, moderate confidence with blue, low and very low with yellow and red respectively. So you can see that the specific drugs which have a very significant lowering effect on HbA1c, both in drug-naive patients as well as in patients who are receiving metformin-based background therapy. So, for example, you can see that semaglutide or dulaglutide, they have a very significant effect on HbA1c. So apart, however, from HbA1c, there are other outcomes we explored for patients at low severe risk. So severe hypoglycemia, there seems to be no difference apart, of course, from insulin regimen and sulfonylureas, which seem to have a significant impact on the increase of severe hypoglycemia in patients receiving metformin-based background therapy. So these should be kept in mind when choosing therapy in patients with low severe risk. There are, of course, other differences, like the differences in the effect of agents on body weight, systolic blood pressure, and diastolic blood pressure, which should be kept in mind when choosing therapy in patients at low severe risk, where there seem to be no differences in other important cardiovascular outcomes. However, based on mostly on the results from cardiovascular outcome trials, there seems to be significant differences for patients who are at increased cardiovascular risk. Firstly, we try to explore whether there's any evidence for patients who are drug naive at increased cardiovascular risk, and we found actually 100 studies in which treatment interventions were used as monotherapy in drug naive patients. However, none of the identified trials exclusively recruited drug naive patients at increased severe risk. So actually, we could make no recommendation about patients who were drug naive at increased severe risk. On the other hand, in patients who are at increased severe risk but use different agents as add-on to metformin, there seems to be significant difference between the classes and the agents in terms of their effect on all-cause mortality. You can see, for example, that semaglutide and the dapagliflozin have a very significant effect on all-cause mortality. And we have quite some confidence in our results mostly high or moderate. And the same applies also to cardiovascular mortality, which seems to be reduced significantly by specific agents or drug classes. And the same applies, of course, to hospitalization for heart failure, where most or almost all SGLT2 inhibitors seem to have a very favorable effect on hospitalization for heart failure. And similarly, for stroke, it is mostly semaglutide and dulaglutide which show the favorable effect. However, there was absolutely no difference between the agents in terms of their effect on myocardial infarction, except for liraglutide, which seems to touch on the line of no difference, the 95% confidence interval, whereas for retinopathy, there is a small signal for semaglutide, which needs to be verified in future trials. Regarding amputation, we show that there is no difference between the individual agents apart from mechanical closing, which seems to increase the incidence of amputation based on data from cardiovascular outcome trials for mechanical closing, and liraglutide, which seems to have a favorable effect on the incidence of amputation, whereas in terms of end-stage renal disease, our analysis mostly verified the results from individual renal safety and cardiovascular safety trials. Now, the major question, however, which is being asked by most clinicians and researchers, is whether the conclusions from cardiovascular outcome trials also apply to patients with multiple risk factors and not just to patients with established atherosclerotic cardiovascular disease. We could not address this question using data from the cardiovascular outcome trials, since they mostly reported aggregate results for a mixture of patients, both with established and cardiovascular disease and with multiple risk factors. However, this question could be addressed by means of subgroup analysis, which have been meta-analyzed in a series of papers which have been published in the last 2 years. So Christensen in 2019 tried to address the question whether GLP-1 receptor agonists have a different effect in patients who have got established cardiovascular disease versus patients who have got multiple risk factors. And as you can see from the therefore interaction test, which is being reported in the article in Lancet Diabetes Endocrinology, which was bigger than 0.1, there is absolutely no difference. Hence, the overall findings regarding the beneficial effect of the GLP-1 receptor agonists on MACE also apply to every individual group. So both to patients with established atherosclerotic cardiovascular disease, as well as patients with multiple risk factors. This finding was also verified by Mannucci and colleagues in the meta-analysis of subgroups analysis published in Diabetes, Obesity, and Metabolism in 2020, who also verified that the P4 interaction test showed no difference. Hence, the overall findings also apply to every individual group. On the other hand, Zelniker and colleagues published in the Lancet in 2019 their findings for whether there's a difference between patients with established cardiovascular disease or patients with multiple risk factors. And as you can see, the therefore interaction value was smaller than 0.1, denoting that there is indeed a difference between patients with established cardiovascular disease and patients with multiple risk factors. So the overall effect estimate cannot be used in both groups. So this should be kept in mind when using or when one is to choose treatment in patients with multiple risk factors rather than patients with established cardiovascular disease. Another point that is quite often being raised by clinicians is about the clinical relevance of the use of GLP-1 receptor agonists or SGLT2 inhibitors in patients without established atherosclerotic cardiovascular disease and with a small number of multiple risk factors, so 1 or 2 risk factors, whether any beneficial effect would be clinically relevant. Palmer and colleagues have recently published a meta-analysis in the BMJ using a very similar methodology like our paper in the Annals of Internal Medicine. And they only recently, so about a month ago, they published the recommendations in the BMJ. So despite the fact that they assumed that any beneficial effect of GLP-1 receptor agonists or SGLT2 inhibitors would also apply, so would also be the same in any category of patients, irrespective of the presence of atherosclerotic cardiovascular disease or multiple risk factors. So they thought they would always be beneficial. They also admitted that the clinical relevance of this effect on patients with minimal risk factors, number of risk factors, so in patients with less than 3 cardiovascular risk factors, is really should not be so these agents should not be used in patients with less than 3 cardiovascular risk factors, and therefore they suggested that SGLT2 inhibitors or GLP-1 receptor agonists should not be used in patients in those specific patients, but rather the choice of agents should be guided by other parameters like the anti-hyperglycemic efficacy of agents, their safety, or their cost. Another point that is quite often coming up is whether there are any differences between the individual agents or whether any beneficial effect is a class effect. As you can see from the following slide, there are differences between individual agents. So you can see, for example, in this slide, that there are certain GLP-1 receptor agonists like lixisenatide, which have absolutely no effect on the all-cause mortality, whereas other GLP-1 receptor agonists have a very favorable effect. And the same applies also to SGLT2 inhibitors like ertugliflozin or canagliflozin, which do not seem to have any effect on all-cause mortality, whereas other SGLT2 inhibitors like empagliflozin do have a beneficial effect. So I think it would be more appropriate to talk about a drug effect rather than a class effect, at least for some of the outcomes that one might consider, like all-cause mortality, body weight. So you can see here, for example, that again, lixisenatide, exenatide, extended release, and dulaglutide do not have the same effect as other agents from their drug class, and the same applies to systolic blood pressure. You can once again here see the effect of lixisenatide, how it is quite different from the effect of the GLP-1 receptor agonists. Many clinicians are also wondering whether GLP-1 receptor agonists could be combined with SGLT2 inhibitors, and whether these would have even more favorable effect on specific outcomes. And we have tried to summarize the evidence which is available for a combination of GLP-1 receptor agonists and SGLT2 inhibitors. Unfortunately, there are only a small trial. There's only a small trial number of RCTs which try to address this question. And as you can see, they mostly focus either on HbA1c, on body weight, or on systolic blood pressure. And unfortunately, regarding the question whether there is an additive, more than additive, or less than additive effect, there was absolutely no evidence about the effect of the combination on cardiovascular outcomes, whereas there was only limited data regarding the effect on other glycemic or surrogate outcomes. In terms of the differences between simultaneous or sequential initiation of this combination, a similar question had been addressed for DPP-4 inhibitors in the VERIFY study, which showed that regarding glycemic control, simultaneous initiation was better than sequential initiation. However, the data which are available for GLP-1 receptor agonists and SGLT2 inhibitors combination treatment are only limited and would not address this question. Another point which is being often brought up is whether the conclusions for GLP-1 receptor agonists or SGLT2 inhibitors also apply to specific group of patients like elderly patients. You can see from this slide that for GLP-1 receptor agonists, there was absolutely no difference between elderly patients, so patients less than 65 years, or patients more than, who are older than 65 years, in a series of outcomes. Unfortunately, the data which have been 65 are not enough for researchers to summarize them regarding the differences between those two groups in a series of articles. Similarly, regarding SGLT2 inhibitors and their use in specific groups of patients based on age, for the majority of outcomes like MACE, all-cause mortality, CV mortality, cardiovascular death, or hospitalization for heart failure, and the composite renal endpoint, there seems to be no difference between patients who are older or younger than 65 years. On the other hand, regarding the effect of SGLT2 inhibitors on patients who are younger or older than 65, there do seem to be differences in terms of their effect on stroke and on hospitalization for heart failure. However, no conclusions can be met about these specific differences since subgroup analysis are mostly regarded as observational data rather than data from randomized trials. So to summarize my presentation, based on the available evidence, metformin is still regarded as the first-line treatment for drug-naive, or should be regarded as first-line treatment for drug-naive patients who are at low CV risk. Unfortunately, there is no evidence about the initial treatment of drug-naive patients at increased CV risk. In patients who are at low CV risk on metformin-based therapy, choice among available agents should be based on their effect on other efficacy and safety outcomes because of the lack of difference in vascular outcomes. For patients at increased CV risk on metformin-based therapy, the optimal choice between specific GLP-1 receptor agonists and SGLT2 inhibitors should be based on the cardiovascular profile and guided by patient preferences and therapeutic priorities. The results that I presented to you seem to apply to patients who are older than 65 years as well as patients who are younger than 65 years. However, there is no evidence about the specific efficacy on cardiovascular outcomes of the combination of SGLT2 inhibitors and GLP-1 receptor combination therapy. Thank you very much.